You are listening to Walking Home from the ICU. We will be exploring how to save and preserve lives in the ICU. All opinions and views shared are unaffiliated with any organization. What would happen if we expected to be able to communicate with all of our mechanically ventilated patients? How would that change our focus, practice, and patient outcomes? Dr. Lance Paddock has spent his career advocating for greater humanity and communication in the critical care world. Dr. Paddock, thanks so much for joining us.
Sure. Thank you, Kelly, for inviting me.
So can you give us a little outline of your career and what led you to be so invested in communication in the ICU?
I'd become invested in a patient's life and her recovery. She had a bilateral lung transplant, and she was previously an opera singer. Her daughter was very engaging, and I think, that helped a lot of us become stakeholders in her recovery. She went on from having an endotracheal tube to getting a tracheostomy and had this for months and eventually ended up passing away, unfortunately. And then that night we, developed this two-sided laminated, dry erase board that was made out of, styrofoam and dry erase surface from Kinko's. And we went back to the hospital and used it with her, and it was brilliant. And at that point in time, I thought, we had basically discovered sandals. Now something as simple as a pair of sandals can be used by everybody. But our director of evidence-based practice at the time, Dr. Anna Galinsky, I was referred to her for, making any sort of clinical practice change. And she said, well, let's look at what the evidence shows. And when we looked at the evidence, well, there had been no research done on what was actually effective. And, while it may be intuitive to have words and phrases on a board, that may not be shown to actually be the most effective method. So I was then pressed to do a research study, which I was very reluctant to do. I was, this was not my trajectory. I just wanted to solve a problem.
Uh-huh.
And so we went about doing this research study. We designed it in a way that we would basically be presenting patients with a list of survey questions, open-ended questions, asking them, things that they would want to communicate, things they didn't get to communicate, what were barriers to them being able to communicate, what was helpful, what did providers do that, made it possible, just to try to glean from every direction from patients what would be best to help them communicate while they're intubated and unable to speak. We approached them within 24 hours of the tube coming out, and we only approached patients that had accumulated at least 2 days of intubated experience. So it was for optimal recall, and then also to have at least some point of reference that they could, talk about. And we approached a total of 149 patients, 13 question survey, and got tremendous feedback about this communication board. And it became apparent that, our idea was it would be a two-sided dry erase laminated board. So a clipboard, so that you could slide paper in and out, because sometimes patients can write legibly and the board would be too limiting at that point. But then when their writing becomes illegible, they can just start using the dry erase board. But the clipboard was too heavy. The weight of a clipboard, we couldn't find a clipboard that was lightweight enough that a patient could actually lift it. And we removed the metal clip and made it a plastic clip. And so we just basically had to abandon the clipboard altogether and just say, well, we'll just save that for when patients can write. So the human factors that had to go into making a communication board for critically ill patients to use was far from being intuitive. And it really required gathering all these small details. And that's how we developed the Easy Board.
As you explain all of that, I am just astounded by how much work and thought goes into creating that kind of tool. So why at the time was communication with your patients so important to you? And what did you learn about it being important to your patients?
Sure. So why was this so important? I guess, as healthcare providers, as nurses, we go into this field because we want to help people. And, if you were to see someone who had fallen off their bike, your instinct would be to help them up, right? Especially if you saw them suffering.
Mm-hmm.
And, to just walk by that experience, witnessing it, it's kind of counter to what is most intuitive to, people who go into healthcare. And so I think I was just driven to address that suffering that goes on behind, being trapped behind that ET tube, and the powerlessness, the interviews that I heard. So, we had 45-minute interviews with each of these 149 patients. I heard stories that you would not believe. And I know the coworkers that I worked with, they were all phenomenal nurses. I don't think any of us, and I probably was, maybe one of them, I don't know. But, the things that we don't realize that are happening because there's no voice, there's no narrative put to the experience. It's all silence. We're not experiencing it. We're experiencing walking into a room, hanging meds, doing things on time, changing dressings, doing all these tasks. It's all task-oriented behavior. But what we should be doing when we walk into a room is first, before we do anything else, unless we have to run in and resuscitate them, we should be walking up to the patient and saying, hey, since the last time I walked in this room, is there anything that you'd like to communicate with me? And empower them and give them a sense of power, because they're just lying there powerless, completely have no control. Nurses have always been the gatekeeper for all patient care. Doctor's orders are not. Nurses make or break, a patient's experience. And so if that patient's going to get the opportunity to communicate, it's going to be because a nurse is taking care of that patient, values that, and it's going to make sure that happens and isn't going to give up. It's going to make sure they have the right tool in place. It's going to be sure that the patient is given enough time to participate and seek that information out. You can't just walk into a room and talk to a patient and expect them to nod and be okay with everything. You wouldn't be okay with that, and neither would I.
Huh. I hadn't thought of it that way because I haven't experienced that. You're totally right. I want to articulate my thoughts, my feelings, my needs. But sometimes just with my patients being awake, I feel like we kind of get along, muster by, just with nods and hand signals and short words on a board. But you're right. I wouldn't be okay with that. I wouldn't feel connected.
Yeah. Is being connected, but also, I would say, if something's working, there's no reason to change it, but that patient may be looking around and realizing there's no other option. So they've somehow accepted that muted experience and really being in a passive voice throughout the entire recovery until something really pressing comes to mind. But they're constantly, like the patients, they told me, I tried to tell them and I couldn't. I tried to tell them and I couldn't. And no matter what you do, you try to get it across, but nothing works. And eventually you give up. And this is what all these patients do. At some point they give up. And I think there must be some psychological component to delirium where, I remember taking care of patients and doing horrific dressing changes to wounds, and the patient literally being non-responsive, but not on any sedation. Like they have totally left their body. And at what point of being trapped behind a tube and a ventilator and being there day in and day out, not knowing what's going on, not being provided the opportunity to communicate, do you withdraw and completely have to leave your body in order to survive that experience? And is this really our standard of care? Is this really how we consider standard of care? Because it's not in our chart. We don't have to check a box that we've communicated with the patient. We don't have to chart a temperature. 4 hours hasn't gone by where a temperature is not checked, where someone can say, hey, you didn't check a temperature. Mm-hmm. No one is going through the electronic medical record. No one's going through ICU rounds and saying, hey, you haven't communicated with your patient all day. Like, no one is doing that. Who's doing that? No one.
And that makes so much sense, because nurses have such good intentions, but we are so busy, and survivors have mentioned things like wanting to write on a board, trying to write on a board, signaling that they want to communicate, and having their hands swatted away. And maybe the nurse just didn't understand that they were trying to communicate. Maybe they were just used to patients being unresponsive, sedated, completely delirious. But survivors have talked about the frustration of being locked in their body and being completely isolated, but that was not a focus. Communication was not an emphasis. And we're not trained as ICU nurses to communicate with our patients and when we have an altered form of communication. So as you've created this tool to open up the gateway of communication, how have you seen that impact patients' short and long-term outcomes?
Sure. Well, yeah, it's interesting you say this, making this tool has kind of served as a gateway, because we actually had one of our patients was a producer, and he was very verbose. And every time I asked him a question, he went on kind of like I am, very, very long-winded, and never kind of stopped talking. But one thing was very enlightening when he said, I'm going to actually read his quote. Okay. It says, it would create an interface between the patient and the staff that would in a way formalize the requirement that they pay attention to what the patient is trying to say. Even if I didn't use it, I could wave it and say, I matter, I could be heard. It would be like a passport. I have a stake in this. It's not just about you acting on me. It's about my being able to tell you what I want, what I'm doing. And he says, I believe the concept itself is very strong, because it would both obligate the staff to stop and listen with a fresh ear, instead of saying, oh, well, they're intubed, they can't talk, let's just write them off. It could inspire, that is to say, instill hope and empower those who are not as strong-willed as I am. And that was his quote. And it's very powerful. It really kind of gets that message of a gateway, right? Like here we have now an opportunity to implement a communication tool. How do we now then adopt this as a systematic practice to provide communication aids or augmentative communication resources to patients who need them? Even as simple as a pair of, their glasses and hearing aids. These are also communication tools. If I'm talking to you and you don't have your hearing aids in, you can't hear me. So, this can also, misdiagnose delirium. And I remember hearing this at our presentation at IHI last December. One of the presenters was sharing her experience where everyone had kind of diagnosed this patient as being locked in and completely non-responsive and delirious. And, someone provided him hearing aids, and he heard, and he came to life, like as if you put batteries in the back of a toy. And she couldn't believe it. And she'd never forgotten that experience. And so, I mean, it's real basic and simple sometimes, right? We want to save the glasses and the hearing aids and put them away somewhere safe, but that's not where they should be. They should be beyond in the patient's ears and things,
It's just such a shift in perspective, Dr. Paddock. For decades we've deeply sedated, so communication wasn't even anywhere near possibilities. And now that we're transitioning to this humane care, seeing and treating our patients as human, now we have to really evaluate those things that were never even an option before. I'm humbled by hearing that story about the patient getting the hearing aids, because I had a patient years ago that had West Nile meningitis, and he was encephalopathic. But time went on, and everything seemed to be getting better, but he still wasn't responding to us. And it was a speech therapist that came and put the amplifier headphones on and asked him to open his eyes, and he opened his eyes, and he followed every command and was totally oriented and was absolutely there. I don't know how long he had been there, but he was deaf, completely deaf. And that was so humbling. How long was he isolated for? Well, we forgot those elements of communication.
Right. And so, when we, at my job, at Seattle Children's Hospital, we have this culture of safety. And whenever people encounter a near miss or perceive an opportunity where something could have been missed, but they caught it, or let's just say a real miss, you look at systematic processes that are in place and you say, okay, what can we put into place to prevent this from happening again? So if you look at a situation like that and you say, okay, how do we prevent a patient from not having their hearing device made available when they're in the hospital? You have to kind of look at systematic processes. Well, you can't send it home with the patient. If the patient has, some sort of communication vulnerability where they need devices, whether it be glasses, hearing aids, or communication boards, or whatever it is, then this needs to be part of a communication plan. And a communication plan should be a part of every single patient's care plan of a patient who can't communicate using their voice, who can command, when you come and don't come into a room and what you do, and ask questions. If you can't verbally, communicate with your providers, there should be a communication plan in place. And that should be shared across the interdisciplinary team. And when you look at this A, B, C, D, E, F bundle, you go, okay, if communication is the central core to this program, where is the communication plan? Okay, we've got C. C says, consider a different drug of sedation or analgesia. Okay, well, that's a missed opportunity. C should be communication if communication is the central platform for the A through F bundle. But if you look through this bundle, the devil's in the details. There's absolutely no mandate that any of these patients who are intubated or trached and can't speak, that there be a communication plan in place, or even what a communication plan would consist of. So there's a gap, and then when you look at other things that create accountability, like documenting, if you went to a chart and temperature wasn't documented for 3 days, would you assume that the temperature was just taken, but it just wasn't abnormal, and so no one document? No, you'd think that no one knew if the time. You'd say, well, I have no idea if this patient was febrile during this time or was cold, and this is why the blood pressure and the heart rate were so low. So if it's not documented, it's really not part of the patient care, right? It's just some ad hoc, privileged opportunity. If you happen to have a nurse that knows enough about it or cares enough about it, maybe they have the app on their own device and they use it, but that's not systematic adoption. You certainly can't drive outcomes with ad hoc situation-specific or provider-specific interventions. I've looked at this bundle and looked at systematic change and and I can provide you an idea of what I think if we were to implement 4 new elements of performance within this bundle that would centralize the patient's ability to communicate when they can communicate. It would be, doing a checks and balances with communication in the ICU rounding period. So when that sedation's turned off at 4 a.m., the doctors, they come around and, when they ask about the antibiotics, if the cultures are back and if they're matching the culture sensitivities, they ask about communication. Is the patient able to communicate? No. Okay. Well, what have we provided them? What tools don't work? Have we called a speech language pathologist to come to the bedside and make recommendations? Okay, great. We'll follow up with those recommendations later. And then you'd look in the charting. And in the charting, along with vital signs and other things, you would have documented what communication tool the patient uses that's effective. And that might change from day to day. One day they might be able to write with pen and paper. The next day they need, the communication board, or maybe, this patient can't do any of that and they can just do hand gestures.
But even that would be so much information for us. What's causing the change in capacity? Is it delirium? Is it a weakness? It would tell us so much to be able to look back in charting and see what has changed and make us ask why. And I think it would help our diagnostics.
That makes a lot of sense. Yeah, it would tell a story, right? Because a patient's cognitive and physical capabilities, they wax and wane. And that's why there's not one tool that, fits all.
Mm-hmm.
And that's why you need the full armamentarium of tools and devices. And also why you need, to phone a friend sometimes and have a speech language pathologist make some recommendations. But, there's a Speaks To program out there that Dr. Mary Beth Happ has put together. And this has been actually shown to create sustainability in practice change, and improve the way in which providers are able to pick and choose and use a variety of different tools to help patients communicate. It's SPEACS-2. And right now it's available for free. Anyone can go to it. It's 6 10-minute sessions, so a total of 1 hour. And you can get CEUs for it as well. But it kind of goes into all the counterintuitive nuances of what actually makes a provider more successful and being able to use tools and use hand gestures and things. It's funny. I just mentioned there's a story that I heard at this IHI presentation. One provider walks into the room and says, "Squeeze my hand once for yes, 2 for no." The next one comes in the room and says, "Blink once for yes, 2 for no." The next one comes in and says, "Squeeze my finger, 2 for yes, 1 for no." The patient can't remember what's going on.
Yeah.
They can't keep up with it, but each provider thinks they're being, hey, I'm being patient-centered. I care, and they are.
Yeah.
But there's no reason why everyone should be changing what the rules are in terms of what means what. But all this stuff could be on a dry erase board in the room, and people could be consistent. And that's not intuitive to me. I just learned that myself, and I've been, involved in this for 30 years.
Yeah, that is, I had never even thought of it that way, because we do that. We do what makes sense to us in the moment, but you're stepping back and looking at the big picture, and especially from the patient's perspective.
Right.
And how have you seen this approach impact patient care?
Sure. So I would say I don't know that we actually have ever really seen systematic adoption.
Mm-hmm.
And, there was a huge effort back in, I think, 2009, maybe 2011. We were working with one of the directors of the Joint Commission, who was in the health disparities division. And she was such a champion, Amy Wilson-Strongs, such a champion for patient advocacy and looking at the standards of care around patient communication. At the time, there wasn't even any direction on what providers should do other than, there was really nothing specific at all. So there was actually new standards written at that time, I think in 2011, new elements of performance around standards of care. And the best that they could do actually was to write these new standards that communication tools should be provided to patients, but the level of standard was non-punitive if not fulfilled. In other words, let's say there's 3 different categories of standards of care. Category A, if you don't comply, you get dinged for it. You get points off and you have to reconcile the problem. Level B, they're basically suggestions, but you don't have to fulfill them. And that's where this falls. So the best they could do was write them, but not require that anybody follow them. Uh-huh. And so they're just lingering there as suggestions, still no mandate. And, Dr. Happ came out with an article just recently, 4 decades later, where are we now? And it's crazy. I mean, if any of these patients actually had a voice at the time, we would in real time be aware of this tragic silent crisis that's going on. But none of us are called out on it at the time because none of these patients are able to do that for themselves. And, it truly is a silent crisis.
Well, we're still struggling with getting sedation lightened and turned off.
I know.
I mean, so that's one of the barriers, how to standardize it. But what comes before allowing patients to communicate, allowing them to have functional brains, right? And we still struggle with that. We have research from 20, 30 years ago showing that sedation's harmful. It hurts patients, and yet we continue to do it. And I think communication has fallen at the wayside in so many ways, along with our persistent sedation culture. But I love the focus that you bring back into realizing that these are humans that we're treating, not just bodies, not just individual organs. These are people with souls that need connection, interaction, need to know that they can be heard and have their needs met. And what recommendations would you give to the ICU community to be able to standardize this, to move in this direction, to have this shift in perspective and priority?
Yeah, and I get what you're saying. It's almost kind of a catch-22. At what point do you break the cycle? So you wean the sedation off at 4 a.m., you make rounds at 6 a.m., you start your breathing trials, and then 11 a.m. the patient, comes to, can't communicate, becomes panic-stricken, shakes the bed, gets misinterpreted as trying to pull out the tube when they're just trying to tell you to suction the tube, or they want to know when the tube is coming out, or their mouth is full of saliva and they can't swallow, or they've got a hair in their mouth. These gestures get misinterpreted, and at some point the sedation gets turned back on. Yes. Not because, we're ignoring the patient or we're ignoring the fact that sedation causes harm. I think we're doing it because it's the best alternative to letting that patient suffer. So what does a provider have? You have 3 options, right? No, let's call it 4. They turn the sedation off. They can do one of 4 things. They can extubate the patient. Great. Perfect. Or they can communicate with the patient. The patient can't get extubated. And then, or they can just sedate the patient, or they can let them suffer. And so they're not going to probably let them suffer. So they're going to resedate the patient. And I guess
I have to interject, sedation is not liberation from suffering. It just masks their suffering.
Yeah, I get it.
We don't see the suffering underneath. That's my little interjection, because we hardly ever sedate patients here because we don't want them to suffer. But it's uncomfortable for us to see them be anxious and confused and delirious. And so it's more comfortable for us to mask it with sedation. But that is one of the options. That is what happens. That's the way I learned sedationifications, which is not what they're meant for. But as a travel nurse, they just said you just turn the probe down enough to see them flail all fours, then you know that they're uncomfortable and you turn it back on.
Yeah, it's too unfortunate. So, I think the Society for Critical Care Medicine really needs an overhaul on their ABCDF bundle. And, we have a letter to the editor that was recently accepted that kind of highlights the need for communication to be re-examined, and that it's really not about, communicating with the family, although that's great, and engagement with the family and the patient. It's about the patient communicating with you. And this impacts everything. So I'll give you an example. I had a physical therapist. I'm going to say her name is Nicole. She said, this is so important. I can't tell you the number of times I come to the bedside to do passive range of motion, physical therapy, early mobility, and the nurse stops me from going in the room and says, please don't go in there and wake her up or wake him up. I just got them settled. And because the patient has no means to communicate, because they're terrified and trapped, the nurse has nothing else to work with except the medication. So she resedates the patient. She gets them. And the last thing she wants is for that patient to get early mobility, because it will undo everything they just got done doing to get them settled, because they're not avoiding, but there's this absenteeism around communication, and it's completely absent from the care paradigm. I don't get it. 4 decades we've been talking about this. What is it going to take for this to become rudimentary, just as rudimentary as a vital sign? Every 4 hours, you're assessing the patient for their ability to communicate unless they're sleeping. And you always walk in the room and let them communicate before you do anything else. You have this embedded in your ICU rounds, and it's challenged and it's answered. There's a checks and balances. There's referrals to speech language pathologists. There's electronic medical records that include communication method that gets documented on an hourly basis. There are communication plans in place that clearly articulate what's needed to optimize this patient's ability to communicate. And lastly, there are quality assurance observation audits where someone is anonymously, observing patient care, and they observe on a consistent basis. Providers, when they walk in the room, approach the patient and provide them their care plan directed communication tool as the first intervention. And they don't turn their back on the patient because you walk out of the room looking at the patient, making sure they're not left with a need unacknowledged. Then you can keep your sedation off. Then you can mobilize your patient. Then you don't have to worry about waking the bear, so to speak, as it might be suggested when someone goes in to do early mobility range of motion exercises to someone who just got, settled, so to speak.
Oh, Dr. Paddock, I love it so much. It just speaks so much truth to me, and it feels right. It feels like what medicine should be, and I know that it can be. I see it so much in my Awake and Walking ICU that we can see our patients and treat them as humans when we allow them to be awake and talk to us, and we can connect with them. I am so grateful for all your wonderful work and vigilance over this aspect of medicine and critical care. And I think that you will see fruits of your labors in the time to come.
Well, hopefully with this, one of the positives from this crisis, and I realize, delirium has, let's say, 20 different, contributing factors. And there's this cytokine surge, and, there's sepsis and everything. But when it does fall on us, because we have failed to communicate or allow this patient to communicate, and we are sedating when we have other options, and it's not the other factors, then we are contributing to harm, and we are part of the problem, and we are part of the delirium rates being persistently high, and we are part of the mortality and all the complications that ensue from this.
I love it. And I think with our COVID survivors, at least I'm seeing younger and younger people coming in. And when they have spent weeks being sedated and they come out of this with cognitive deficits, PTSD, all the things, I expect to see them on social media and coming back to the medical field and saying, what happened to me? Why am I like this? Why is my life like this? They're going to have a new voice that we haven't heard the older generation have yet. And it's going to come back on us. And I think that is when we're going to be very obligated to open the gateway and actually talk to our patients moving forward.
Well, thank you for creating a platform to increase awareness. And, eventually we will get there. And I feel like the time is now.
I think so. Thank you so much for being a part of it and leading it.
Thank you so much.
If you want to join in on the conversation, leave a voicemail at 801-784-0472 or reach out to me on Twitter.